muscular dystrophy. I'm going to concentrate on the presentation of these children, the diagnostics we use, the family implications, the role of the different multidisciplinary teams in their management, the steroids that we use for these children and their implications, and what we have to do as clinicians for their care, the systemic involvement in Duchenne. I'm going to touch very briefly on emergency care and imaging therapies. So I currently work at John Walton Muscular Dystrophy Research Center, and this was part of the consortium team that has published and updated the guidelines. And I feel really very proud to be able to share this with our registrars, who are always very knowledgeable. But the problem is, because we do not have an established neuromuscular service, there are certain things that really need to be shared by somebody who's really doing the job. I have no disclosures. So at the moment, Professor John Walton, initially when they started looking at children with Duchenne muscular dystrophy, we started to have, different children presenting with becker or Duchenne muscular dystrophy, the dystrophinopathies. They started to look at the different presentations that these children have, and then the start of clinical trials and, looking for a cure for this devastating disease led to a huge center just being focused mostly around dystrophinopathies and other limb-girdle muscular dystrophies. People now are starting to divide this into the clinical care, which is my job. Then there is a clinical research team that looks at the gene therapy trials in Duchenne and other disorders, the diagnostics regarding these diseases, basic research, looking at animal studies and what might come in the future as a future cure. This is still an incurable disease. And also looking at a very important aspect, which is the strategic partnerships and networking around the world to try and expedite the knowledge in this disease. A lot has changed over the last few years, especially in terms of diagnostics and looking at muscle MRIs especially. This is not the right context to discuss this today, but this is one of the very important things I am learning at the moment, and I hope in the future to be able to pass this to my colleagues, of looking at muscle MRIs and trying to understand the different involvement of muscles, not just in Duchenne and Becker, but in other limb-girdle muscular dystrophies. So if we come back to Duchenne muscular dystrophies, we all know that this is an X-linked muscular dystrophy. The prevalence, depending upon where you read it, it's around 4 per 1,000. Usually you have to have a multidisciplinary care. And now there is the standard of care stress on the importance of multidisciplinary care in improved survival. So we do not do our clinics just with doctors and nurses at the moment. We have joint clinics with physiotherapists, with psychologists. We have joint clinics with the respiratory teams, joint clinics with the cardiology teams. This is because this is such a complex disease that has got multiple stages, and every stage has got different implications that we as clinicians should be really very aware of. Focusing on the quality of life has really been a big thing over the last few years. And this is specifically because the improved standards of care meant that these children are now living longer, and now they are transitioning to adult care. This came with its own challenges, because in the past, these children used to die at a very young age. So these services really did not exist in the past. So the guidelines were initially written in 2010 about the standards of care in Duchenne muscular dystrophy. They've been updated in 2018, and back in 2018, the original guidelines, the focus has changed, that the patient's need for prolonged survival now have changed. So we need to be, anticipating new problems. Also, we have to consider the implications of the emergent genetic and molecular therapies, although this up till now remains still at clinical trial level. So there were a few networks, as we discussed earlier, the strategic partnerships and networks that put their heads together to try and get these guidelines to see the sun really. The CDC, the Treat Neuromuscular Disease Network, and the Muscular Dystrophy Association, and the Parent Project Muscular Dystrophy Associations. And the role of associations and patient-led and muscular dystrophy UK associations has got a very huge part in initiating and allowing research to continue with a huge advocacy work for patients. So when we look at a child with Duchenne muscular dystrophy, we as clinicians are usually involved in the diagnosis stage. Initially, these children will be walking, but then later, unfortunately, they tend to lose their ability to walk. This itself can be divided into an early non-ambulatory and a late non-ambulatory phase. The reason we are dividing them into these phases is that each one of these phases has got its own implications and its own needs really in terms of the patient and the family. And we as clinicians involved in the care of these patients really need to be aware of the different stages and what the patient actually needs. So who is really involved in looking after children with Duchenne muscular dystrophy and as they grow into adulthood? The neuromuscular team, so the team I'm working with at the moment, looks at children and adults as well. So they do not really need to transition. However, you need the rehabilitation team, you need the gastroenterology team, nutrition, you need the endocrine team because these children are going to be on steroids. You need the respiratory team because we know as the disease progresses, these children are going to lose their respiratory muscle function. We need the cardiac team because we know that as they progress, they develop cardiomyopathy. We also need the bone health team, not just because they're going to be non-ambulant and unable to move, but also because of the secondary effect of steroids on their bones. We need the orthopedic team. So these children are prone to develop lots of fractures because of their deterioration in their muscle function and their stability, but also because of their dependence on wheelchair as they grow older. We need to have the help of a psychosocial team, and we need a transition in services that do not see pediatric and adults. So the recommendations at the moment are based on appropriateness and necessity. There is no nice guidance per se that you are going to refer to, but this is the standard of care that is being adopted in all neuromuscular centers around the world. If we go back to these children as they present, these children can present very early on. They can present as just being hypotonic children. So we have to always remember as clinicians, when we are faced with a hypotonic child, to remember to do the creatine kinase. It's usually not a very expensive test to do, and also might highlight for us that this child has actually got, a dystrophy, let alone it being Duchenne. Also, one of the symptoms that were noted in these children is that they've got decreased head control when you try and pull them to a sitting position. So this is really very interesting because we tend to always think of central causes and maybe forget about the neuromuscular causes. Also, we all know that if any child is not walking by the age of 18 months, gross motor delay, we have to really be thinking of doing a CK. And that's something that we teach our medical students, but we also remind ourselves of that as clinicians. Any child who really presents with an abnormal gait, you should always think, could this be Duchenne? Could this be Becker? Calf pseudohypertrophy is a symptom, and noted by most of the parents, and we can pick it as a sign as clinicians as well. Also, these children have difficulty in jumping, running, climbing stairs. They might have flat feet. They might have decreased endurance or ability to keep up with peers. So they might be suffering from PE lessons at school, or when they're playing dafuri fil hilla, they are unable to really finish a shawtain. They just become tired. They might complain of cramps, although for children the definition of cramps might be difficult and some of them might not really be able to explain it, and a lot of these sometimes might present to the pediatrician and they might just be thought as growing pains, or they might just check their vitamin D and find them deficient. So vitamin D deficiency might be a co-occurrence rather than the main cause of the cramps. They might also present with a funny toe walking gait. They might have frequent falls. They might have, of course, the usual classical Gower's maneuver as they try and get off the floor due to their proximal myopathy, or they might actually acquire some motor skills and later lose them. But because dystrophin is not just expressed in the muscles, it's actually expressed in the brain, we can also have behavioral issues. And I think if any one of us tries to remember a child with Duchenne muscular dystrophy, they might remember that they were having some autistic spectrum disorder features, attention deficit hyperactivity, cognitive delay. They might also have difficulties, gaining weight, learning and attentional issues, speech delay or articulation issues. Interestingly, I had a patient before who was picked because he had a febrile illness. And as a routine test, they did ALT and AST as part of the liver transaminases, just because the child was unwell. So they went and did random liver function test and renal function. And the AST and ALT were in the thousands. And these children, they get investigated along the pathway of hepatitis or liver disease. And we know that the ALT and the AST can be also originating from the muscles. So any child who has got an understandable, rise in transaminases, think, could this be muscular dystrophy? Also, we know this is an X-linked condition, so we might have a family history of a maternal uncle having had muscular dystrophy or being on a wheelchair. We always do the CK whenever we suspect a muscular disease, and it's usually high, as in, more than 20,000, 30,000. Then if you have a way of looking further, I did see a few results from Sudan recently due to collaboration with a genetic lab that can actually tell us the exact deletion or duplication that will cause Duchenne muscular dystrophy. This will be great. However, a high CK, in the past, we used to utilize muscle biopsy. The role of muscle biopsy now is really not, it's not a priority. First of all, it's an invasive test in a way. And secondly, because of course now you have easier ways by which you can actually detect deletions and duplications in the gene. If you are trying to look for hotspots, because there are certain areas in the dystrophin gene that are known to cause Duchenne muscular dystrophy and Becker, and you could easily look for these. However, the fact that this test is negative does not exclude it. And if you strongly think that this child has Duchenne or a dystrophinopathy, go ahead and ask for sequencing of the dystrophin gene, because then you are able to pick other genetic problems which are not deletions or duplications. Then a prompt referral to a neuromuscular specialist with an input from a genetic counselor is ideal, because as pediatricians, you all know, we're not just looking at the child, we're looking at the family, we're looking at the maternal uncles, we're looking at the brothers, we're looking at the mother who is pregnant with probably yet another boy who might be affected. So 70% of them have got exon deletions or duplications. And this is just for your interest in case you get to work outside. We do something called the MULPA, which is a multiplex ligation dependent probe amplification, which is basically as if you are trying to look for specific hotspot mutations in the Duchenne gene. And I wouldn't really worry about that if it's not present. If you have a very high CK and the child has got the clinical features, think Duchenne and act Duchenne. That's the most important thing. We always tend to think about the brothers and the maternal uncles, but we forget about the mother. The mother who is a carrier of Duchenne might be manifesting some symptoms herself. The most important and the most serious of these is a cardiomyopathy. So this mother might actually suffer from heart failure and die if she has not been picked up as a carrier and received the 5-yearly surveillance, which is recommended in the current standards of care. She might also want to know her reproductive choices. So a prenatal genetic diagnosis, and we need to obviously follow the ethical guidance for genetic testing of female relatives. What about the sisters of the brother who has been diagnosed in our clinic? Could they be carriers themselves? What are the implications for their children in the future? Would you like to test her now, or would you wait until she's 18 years and she can give you and offer you the consent and then you test her? Because this has got implications and her future husband needs to know this. So lots and lots of questions that you need to answer once you diagnose an index case. There is no newborn screening at the moment generally for Duchenne muscular dystrophy. So what is our role as a neuromuscular clinicians? First of all, once we get the diagnosis, we really need to ensure that this child has got all the lifestyle changes that these children need at their own home. We need to establish their future goals. We need to understand who else needs to be seeing this child apart from me, the cardiologist, the orthopedic surgeon. Do I need to refer to the endocrinologist because I'm going to start them on steroids? Do I need to have this discussion about steroids with the parents at, at depth as well? Some parents, we know that steroids are not a cure. They stop the inflammation that happens secondary to the problem that we have in the dystrophin gene. So it's not a cure. And some parents opt to not go for steroids because of their known side effects to us all. Then when do we introduce steroids? We know that we tend to introduce them at around 5, maybe years, 6 years, at a time when you have a deterioration of function. But how can you define that deterioration of function? Is it something that everybody agrees on? I'm going to go through how we assess these children in a minute, but you need to be thinking about all these discussions while you're assessing the patient. We tend to see these patients in our clinics every 6 months, and we go through a holistic assessment of these children, assessing their tone, any deformities or contractions they develop, any new problems they develop. And we catch up on all the other multidisciplinary team role involvement because we are the central neuromuscular clinicians looking after these children. We optimize their vitamin D levels. They're going to be on steroids, so we need to ensure that they are well vaccinated and covered. Annual flu vaccine, the COVID vaccine now, and the pneumococcal vaccine. We tend to do yearly spinal X-rays and the DEXA scans. Why do we do spinal X-rays every year with the exposure of radiation? This is because they might develop some asymptomatic vertebral fractures whilst they are on steroids. Unfortunately, they will not have the symptoms, so you need to really ensure that you do not miss them. What if I do pick vertebral fractures? Then in that case, I need to start bone health supplementation, things like residronate, zoledronic acid, etc. And the DEXA scans are done every year. So what do I really need to ensure regarding these patients? So as a neuromuscular clinician, I'm not going to be available 24 hours in accident and emergency when these children, fall or break their bones. So I need to ensure that I get an emergency healthcare plan in place for these children so that if they have a fracture, they know they're on steroids. So I need to consider everything from stress dosing of steroids, the type of anesthesia. They've got a muscular dystrophy. I know that they are prone to certain problems in anesthesia because of their muscle problem, and they might have difficulties getting, back after the anesthetic. So I need to really include all this in a document that the child, the paramedic, the A&E doctor will have, as these children present to A&E. What as they grow older and, the parents decided that, this child is now, 28 or 29 years old, he's wheelchair reliant, he's got difficulty swallowing food, he's got a PEG tube, he's got a device to help him with ventilation at night. The quality of life is not great. If they arrest, we do not want them to be resuscitated. So if there is an advanced care planning that is going to advise against PICU admission, that has to be written and communicated via that document. And to be honest, emergency healthcare plans, not just for Duchenne, I think for all our patients, really, we need to think anybody with a life-limiting condition, we need to avail that. And it just makes communication easier between all involved, whether it be family or professional. I need to do a surveillance. What if their swallowing is becoming difficult? Do I need to refer to a speech and language therapy? Do I need to do a video fluoroscopy to ensure that this child has got safe swallowing? What about their respiratory symptoms? I'm going to touch also on nocturnal hypoventilation in a minute. What about the initiation of referrals as they grow older, into adulthood? What about a provision of an alert card? In the past, whenever I used to have my children with refractory epilepsy on steroids, I used to just write on their like an alert on their card, just to ensure that the doctor who sees them knows that they are on steroids. If they become unwell, you need to double the dose, etc. Also, you need to raise awareness for these patients if they want to be enrolled in trials all around the world now, because recruitment might be open for them, transitioning them. What about the psychosocial care and their issues? This is a very huge and big problem. These children are intelligent most of the time. They know, and they're Googling their disease. They know exactly what's lying ahead of them, and they need support along the way. The physiotherapy assessment is a very important part. There is a specific assessment tool called the North Star Ambulatory Assessment, and I'm going to go through this very quickly, whereby you assess specific objective measures by which you can tell whether this child is actually deteriorating or is he stable. And these are important because these are the important things that you use to enroll these children into trials. So I might say, I want a child who has got a North Star Ambulatory Assessment score of X or Y to enroll him in a gene therapy trial, to ensure that I look at a specific group or cohort of children to ensure that my results are not really biased. And they also do a timed function test. How long does this child take to get off the floor? Basically, I am timing the Gowers maneuver of that child. And the longer, the worse, of course, is the prognosis of the child in terms of his motor function. What about the time that this child takes to walk, 100 meters? How much is this child able to walk in 6 minutes? And they found that these timed function tests have got high validity and reliability, and this is where research is going to look at objective and outcome measures by which you are going to look at the implications of the new therapies. Because now we are in an era whereby we are looking at, are these things working or not? If I do not have an objective way of assessing the functional involvement of these children, I will not be able to recommend these therapies. So they have to be consistent and reproducible. So the North Star Ambulatory Assessment, this is what we do in clinic every time a child attends. We ask them, if they are able to stand off a chair, are they able or not? And then I score them a 0. If unable, this is a wheelchair reliant patient. He cannot, he gets a 0. He can stand easily without support. I give him a 2. If he just needs to press and push and then start to stand, then I give him a 1, etc. Is he able to walk? For how much is he able to walk? Is he able to stand on one leg? And I do it separately for the right and the left. Is he able to climb the step? So you bring a step and you ask him to see. Is he able to do it on the right, left? Is he using support or independently? Is he able to descend from that one step to the floor? And is he able to do it on the right and the left, symmetrically or asymmetrically? Lying, I ask him to lie them on the floor and I get my stopwatch and I ask him to stand up as quickly as he wants, hands by the side, just like a soldier. And you time how much that child needs. Rising from the floor, lifting his head to look at his toes where his arms are folded, standing on heels, hopping, jumping and running. And of course, you will not ask a child on a wheelchair to hop, jump or run. So you sort of, you reach a stage whereby if he's unable to do the basic things, you do not go forward. Then we ask about the activities of their daily living. Do they need any assistive technology, adaptive equipment? So children who are, wheelchair reliant have got their own motor skills that you tend to do. And also we do quality of life tool assessment in clinics to understand the implications of the deterioration of function, motor function in these children. So you will hear of different scores if you work in any neuromuscular clinic, things like a Brook upper extremity scale, whereby they look at the ability of the upper limb, because as these children lose the ability to, to stand and walk and, they just become wheelchair reliant, the hand function, the arm function continues to deteriorate. And there are different classifications to assess the performance of the upper limb. So you will hear people talking about a pull score of X or Y. Then you need to think about what is this child is doing at home. How is he able to access the toilet? So if you look at the toilet, the fashionable toilets, what about our children who might be living outside Khartoum, for example, who do not have access to the proper toilet? Are they able to actually sit and get off that little hole in the ground? What if they want to have a shower? Are they able to really stand and be steady during the shower? Here they use a hoist. If you want to weigh a child in clinic who is non-ambulant, or you want to move him from his wheelchair into the couch to do a proper assessment of his spine, for example, you have a rail into the room and you put them onto and just get him through the room through there, as if it's a moving chair along the room, and it just you put him down on the couch. They have these at their own houses to help them move around and mobilize from one room to the other. What about their bus seats? And also they have something called meter eater. As disease advances, the child might not be able to just eat, just move his hand to grab a piece of bread and take it to his mouth, or hold his mobile phone to have a look at his messages. Little things that these children, in their daily life, how are you gonna, do this? Of course, in European countries, they have got their provisional, adult social care, or, social care provision, whereby they have carers who help them with all aspects of daily living. In our setup, probably in Sudan, it will be the family who will be doing all this. How are they coping? What support we can offer for them? The role of orthopedic surgery. Children who are not on steroids, for example, tend to develop a very progressive and quick scoliosis. I hardly see massive scoliosis in children who are mobile here, but you tend to see it a lot in children who opted not to take steroids. And what about, the role of orthopedic surgeries, posterior spinal fusions, and, what about, problems when they've fractured their limbs? What about their equinovarus problems? So these are things that you need to discuss with your orthopedic colleagues. Then we've touched on this earlier, if these children if a child with Duchenne muscular dystrophy on steroids develops an appendicitis, what anesthesia should I give? We know that succinylcholine increases the risk of rhabdomyolysis in these patients, so we recommend IV anesthesia. We have to ensure that their cardiac and respiratory consultation and assessments are up to scratch before they go into general anesthesia. So you have to get either a report from the clinicians who are looking after them, or a new assessment before they go to surgery. So they need to be seen in these pre-assessment clinics. What about the role of steroids? So we all know that we do give steroids as part of standards of care, and we know that there are different forms of steroids. So you can give deflazacort, you can give prednisolone. Prednisolone is cheaper, and there were different modes of it. You can either give it daily, and in the past used to give the 10-day off, 10-day on, which is the intermittent day therapy. There are lots and lots of studies ongoing comparing different types of steroids. The latest, I think you might have heard of it, is called the 4DMD study. And this compared basically children who were on daily deflazacort, 0.9 milligram per kg, versus those who were in daily prednisolone, 0.75 milligram per kg, versus those who were on the 10 days on, 10 days off prednisolone. And they've looked at very different outcome measures, how, their 6-minute walk test, the rise from supine, 4-stair climb, their scores in their North Star. The data have not been published fully, but there are a few interim data that tend to favor the deflazacort in a few of these studies. And regarding the intermittent days prednisolone, although it's good in terms of side effects, and parents, especially, if a child has behavioral problems and that steroids can make this really worse, opt to go for intermittent day steroids. Unfortunately, they have not been really shown to be relevant in a lot of these outcome measures. So now we are opting definitely for daily steroids as opposed to intermittent dosing. So basically, the 4DMD study is going to tell us a lot once we have the full publication, which I think is coming up at the end of this month. Then we've touched on the emergency cards and emergency health care plan, but I thought I'd put it in red because this is something that we can do in Sudan, really. Just a little piece of paper that you tell them to put, and you can easily laminate it, really, and leave it with the child in a place that, mom, if she's rushing to accident and emergency, this child fell, had a trauma, she can take it and communicate the information. If a child has got a serious infection, dental problems needing, anesthesia, or the need for surgery. So I'm just, for the sake of time, this is just for you guys, just to look at there's a PJ Nikolov protocol for steroids. This is not just for Duchenne, but Philip James, PJ, a 31-year-old Duchenne muscular dystrophy, he was on steroids, who had multiple pathological fractures because of his steroids, and he had developed respiratory distress, tachycardia, and hypotension. But when he presented to hospital, he was not receiving his appropriate stress dose of steroids, and he died. And following that, his family, I think, had a huge appeal. And I think out of that, this guidance came, whereby you will be able to look at what doses of steroids you need for these children, depending upon the type of surgery, if it's a minor with local anesthesia, or moderate or major like septic shock or multiple trauma or fractures or severe burns, etc. And I'm sure you guys are all very aware, and our lovely colleagues in the endocrine team have touched on this on a lot of occasions, but I cannot really, emphasize it more, that this is really very important. I'm going to move very briefly now into the systemic involvement in children with Duchenne muscular dystrophy, and as they grow into adulthood as well. So the respiratory complications can be really multiple. They are prone to develop pneumonia. They're going to be having weak muscles and on steroids. So pneumonia and respiratory failure, as you can imagine. Also, mucus plugging, atelectasis, their cough is going to be really very poor. And we tend to assess their peak cough flow when they come into clinic. And if it's below the level, then here we have the luxury of giving them a cough assist device, which helps them to create a negative pressure within the chest to try and assist these children to clear the chest. The respiratory care, basically, every time they come to clinic, we do their forced vital capacity assessment. But also, if a child has manifested any symptoms of nocturnal hypoventilation, we tend to also go and do a sleep study and really look at, the levels of oxygen, carbon dioxide, in their blood, to understand either you can do that either via a transcutaneous or a proper sleep study to basically understand whether these children really need ventilation or not. There are different devices that we tend to use. So down on the left-hand corner, this is the spirometer that we tend to ask the child to blow to get the forced vital capacity. If these children are having difficulties really with their breathing and their spirometry levels show that their FVC is dropping, you give them something called the lung volume recruitment bag, which is basically helps to recruit more and more alveoli to try and improve their breathing. And of course, the NIPI3 there on your upper right hand corner, these are the very user-friendly new ventilators that we use for these children for non-invasive ventilation at home. They use them for 8, 9, 10 hours overnight, and a lot of them do not use them through the day. However, we tell them if they're having a chest infection or feeling unwell, they can actually use their ventilation. You can imagine the amount of support that these children with a completely dedicated home ventilation team, with their physiotherapists, the community nurse involvement, and the education that the parents receive to be able to support these children with this. So we as clinicians, what are the symptoms we should ask or try to screen for when I am seeing these patients in clinic to understand whether their ventilation at night is actually deteriorating? So we ask about fatigue and endurance. Are they being extremely fatigued؟ احنا طبعا الفتيج ده في السودان يا جماعة عندنا عادي، احنا طوالي في حالة اننا فترانين، لكن بنقوم نسألهم انتوا في تحس انه الزول ده بيجي تعبان اكتر من العادي، unable to complete الجوبز والفانكشنز اللي كان بيعملها، unable to finish a school day مثلا and wanting to be returned home early. dyspnea, في any breathlessness through the day. Morning headache. And morning headache is always one of the important points of suggestive of nocturnal hypoventilation, not just in Duchenne, in any child or any adult even. ولك والله يا اخ بصحى بصداع this is not normal. يعني حتى لو لاحظتوا التنشن headaches والحاجات دي they come through the day يعني as a child goes through the day. Like if you wake up with a headache, you should really look at how well you're ventilating at night. بيصحوا كتير بالليل, frequent nocturnal awakenings, وهل لما يصحوا في nightmares and they are unable to really go back to sleep and they feel very frightened. أو العكس, difficult to arouse. مش يا جماعة الناس النوم تقيل وما بيصحوا ساكت, لكن really as time goes by it gets more and more difficult for them to go, and when you wake them up you feel as if they are not really there. Or hypersomnolence, they are sleeping a lot through the day. يعني حكاية إنه طفل مثلا يبدأ ياخذ له day time naps من غير أسباب, ما عمل extra رياضة, ما عمل extra effort. This is again, we take these symptoms طبعا in conjunction, not a single one on its own. يعني difficulty concentrating, لأنك you need really to have good blood gases to be able to do that. Or if they are awakening with dyspnea and tachycardia for any reason, they were being seen in hospital for a reason or another مثلا, they're being monitored ولقوا إنهم والله actually tachycardia حقتهم زايدة أو earlier زي ما قلنا frequent nightmares. فبنيجي نعمل لهم الأسسمنت بتاعهم السليب ستاديز، وبعد ذلك you decide في specific hypopnea indexes of 5 events per hour etc. sleep studies الديتيلز حقتها دائما بتكون مع الهوم ventilation team. you as a clinician ما بتحتاج تدخل فيها، لكن مهم تعرف 200 to refer و200 to raise alarm bells. نيجي للبون هيلث، احنا زي ما قلنا انهم هم عندهم هاي ريسك اوف تروما اصلا بحكم الديتيريوريشن اوف ذير ديزيز. اللور اكستريميتي فراكتشرز اللي هم الفيمر بالذات كثيره جدا فيهم، فانت you need to be really thinking bone health optimize their vitamin D their calcium ensure انهم عندهم good intake قبل ما تمشي للسبلمنتس. احنا دائما بنمشي للسبلمنتس طوالي، لكن we have to ensure الانتاك في الاول، وذات الظروف اللي احنا عايشينها في بلدنا. يعني verify انه عندك normal renal function بتاع الشباب دول. لو في باك بين have a very low threshold انك تعمل له اكس راي عشان تتاكد زي ما قلنا لو عنده اي vertebral fractures. لقيت والله انه فعلا البون density is low. عملت ديكس سكان yearly as per عندهم طبعا زي سكورز بيقيسوها في البون mineral density. you refer them طوالي for الاي في biphosphonate therapy عشان to replenish البون health بتاعتهم. طبعا اخواننا الاندوكرينولوجيست الله يديهم العافيه دي just not just البون health، لكن we refer them لانه يا جماعه الاطفال بتاعنا الدوشين muscular dystrophy برضه بيكون عندهم delayed puberty. So they get subcutaneous monthly testosterone injections to ensure إنهم they do not miss out on this. لأنهم these children as we will touch بعد شوية their psychosocial issues because of the lots of problems that they're having will include also the delayed puberty. نجي للcardiac issues. عادة we do yearly echoes on these children. Cardiac MRI حسب مثلا a lot of clinical trials that enrolls children you look at cardiac MRI لأنه simply cardiac MRI بيديك information which الإيكو ما بيديك لها in other words. لكن إحنا we always tend to look for left ventricular systolic dysfunction و left ventricular ejection fraction وال fractional shortening. دي annually لازم يكون عندك الداتا دي. الفكرة إنه أنت ممكن تبدأ angiotensin converting enzyme inhibitors early as the slightest early evidence of left ventricular systolic dysfunction. عادة we look إنه لو ال left ventricular systolic dysfunction أقل من النورمال between 50 to 55% you should consider ACE inhibitors. Then beta blockers عادة they go here for perindopril and then they add bisoprolol. eplerenone is a last resort. طبعا أي واحد عنده frank left ventricular systolic dysfunction thromboembolic prophylaxis becomes a problem. عادة دي بنشوفها في older children. نيجي للpsychosocial issues. We are nearly finishing. I hope I'm okay for time. I've got a few more slides just to share. Psychosocial issues يا جماعة very challenging diagnosis for the family. يعني كل neurological diagnosis حقتنا as you know they are not easy. لكن here you are dealing with children who have been really well running and playing and jumping and suddenly they're deteriorating. They're going into a wheelchair. They know it's a life-limiting disease. Parents know that they're going to die. Children know that they're going to die. في كل stage they need the support. يعني psychosocial issues في الدوشين you can go and يعني consult the literature a lot going on. social reciprocity, social judgment حقتهم, perspective taking يعني perceiving a situation or understanding a concept from an alternative point of view. عندهم فيه مشكلة affective discrimination, altered social information processing. مشاكلهم كثيرة جدا يعني despite the problem حقتهم هم عندهم problem in just dealing with a social behavior حق day to day life. فإحنا يعني واحدة من الحاجات اللي بنقول إنه كل ما نجي stage بنحتاج psychosocial يعني intervention of different type. At diagnosis you need psychosocial care مش بس للchild to the whole family. قبل السكول entry وهم كل زول هنا بيكون عنده educational health and care plan مكتوب فيها الحاجات اللي هو بيحتاجها. الاكسس للحمام في المدرسة حيكون كيف، لو المدرسة فيها طوابق الحمام فوق ولا تحت، هل حيقدر يطلع الستيرز؟ المدارس ما فيها اسانسير. what is he going to do؟ منو اللي حيكون available عشان يديه السبورت اصلا؟ هل في كير كوردينيتور قاعد عشان يقدر تو allocate منو يساعده في هذه المرحله؟ هل بنحتاج اننا to implicate to start medications for anxiety and depression اللي هي حتما ولا بد is going to happen in these children. How are we going to face the social isolation and withdrawal in these children as they have reduced access to social activities؟ الأطفال بيمشوا بيلعبوا الكورة وبيمشوا للسوشيال ايفنتس، بيمشوا الأعراس، بيمشوا هم ما قادرين، they're always left at home. What about المظر اللي قاعدة معاهم أو الفاذر أو الكيرر؟ So these are all very important. في رول للسوشيال primary care provider. هنا في UK the system is obviously around the GP. عندنا في السودان this is not really the case. لكن generally speaking a GP here plays a very important role in having this relationship مع الفاميلي من الdiagnosis as they go through palliative care, الindependence، الرول بتاعه في vaccinations، nutritional input، السيفتي بتاعتهم، كل الحاجات دي GPs are يعني heavily involved. And when you do any letter for these children you copy their GP in لأنك أنت you are really acknowledging الرول بتاعهم in these children's care really. Just because of time, I'm just going to go very quickly. emergency care زي ما قلت to summarize it. fractures احنا عارفين أي ناس تحصل لها long bone fractures ممكن يكون عندهم risk بتاعت fat و air embolism، وديل طبعا ممكن يكونوا life threatening. Cardiac emergencies الأطفال بتاع duchenne muscular dystrophy once they go into the cardiomyopathy zone هم or their mothers if they are manifesting carriers at a risk of arrhythmias, respiratory failure زي ما قلنا قبل، adrenal crisis لو هم في حالة بتاعت very long term steroids لأنه هسه إحنا ما عارفين نوقف الاستيرويدز ولا ما نوقفها. As these children go and lose ambulation بيبقوا قاعدين على الويل chair ما في guidance, nobody knows really. هل أنا أواصل عشان maybe I am making a bit of a difference on their respiratory care and on their cardiac ولا لا. A lot needs to be answered from research. So they continue to be, although the dose doesn't get upgraded much just for fear of side effects. They tend to have other problems like constipation. They might end up with megacolon, intestinal obstruction. The steroids themselves are a risk for peptic ulceration that might make them present to A&E as an emergency. And we've touched on the emergency healthcare plan, but I keep repeating it because I think it's really important. نجي بالنسبة للرول بتاع البالياتيف كير زي ما قلنا children they're growing older pain بيبقى إيشو، البوستشر حقه في الويل كير شكله كيف؟ هل أنت عندك باك بين؟ إحنا مرات نشوف العيان ننسى نسأله أنت عندك بين؟ هل بين ده إيشو؟ ولو البين ده الجريدنج بتاعه شكله كيف؟ أنا بقدر أعمل what else can I do يعني؟ How can I assist the families يعني in clarifying the treatment goals بالنسبة للعيان القاعد على الويل تشير الجولز حقته مختلفة من الدوشين اللي بيكون امبيولنت ولسه ووكينج ولسه رانينج، وكيف أنا أقدر to facilitate الكوميونيكيشن؟ هل يكون عندي لي سبيشاليست نيرس؟ Okay, I'll finish that. Thank you. How can I address the issues related للgrief والloss؟ بيجون الأولاد دول يا جماعة بيكونوا very sad لأنه their friends are dying. يعني يجي يقول لك كلهم once they reach the 20-25 although حسا عندنا record ناس living up to 40 years وكده، لكن the norm إنهم ما بيعيشوا beyond يعني 30s. they go through all this. On the other hand, it's the era of يعني approved therapies. ما في cure. أنا personally now I am involved in two types of gene therapy for Duchenne. One of them, unfortunately, the Pfizer gene therapy has been put on hold for, you might have heard it on the news, يعني for a few months or up to a year, لأنه there was a sad loss of a child in the United States following just 1 week after gene therapy. فبقى في a lot of safety issues قبل ما الناس تبدأ clinical trials. في exon skipping therapies اللي هو انت الناس اللي عندهم deletions ديل you try and skip الاكزون اللي فيه المشكله وتلصق بيزيكالي الحته عشان تحاول to maintain a functional protein. فدي الحاجات دي ماشيه، لكن احنا في الورلد بتاعنا الناتشورال هيستوري ستاديز ار لاكينج. عاده لو ما عندك ناتشورال هيستوري من الاول تعرف بيها البروجريشن بتاع الديزيز حقك very difficult انك تجي to implicate. لكن احنا we never lose hope and we hope انه لقدام يكون عندنا registry للبيشنتس نقدر نعمل our own outcome measures ونقدر to be enroll these patients يعني in gene therapy trials وكده. So in summary, DMD patients, they need the multidisciplinary care and neuromuscular specialists, they play a central role. لكن as a pediatrician, the basic standards of care are doable. always remember إنه you are not alone in this. معاك الكارديولوجيست، معاك respiratory physician، معاك الفيزيوثيرابيست. وزي ما قلت يعني هم as they grow older the challenges are more. potential issues في عالمنا دائما إنه ما عندنا care provision packages. ده دائما بيقع على البيرنتس، كل الافورت والتايم على البيرنتس وعلى الاميديت فاميلي. عشان كده لما نجي تو كلارك عيان ولا كده لازم نسال يا جماعه يعني how is the family coping, who is offering، منو اللي بيعمل السبورت، هل الهوم فنتيليشن is an issue بالنسبه لنا احنا، هل بنقدر نوفر non-invasive ventilation for these children and what about a transition بالنسبه للناس اللي بيمشوا للادلتهود، منو اللي حيشيلوا مننا to take over as the standards of care become يعني a source of them living longer. Thank you very much. Sorry I had to rush through a lot of the slides, like I think it was a bit too much for 40 minutes, but thank you for your attention.
Thank you very much, Dr. Maha. That is very much enlightening and excellent as usual. There are few questions. What is the exact role of steroid in DMD?
Thank you very much. So basically, steroids, we know these are the strongest anti-inflammatory medications that we ever ever known. المشكله اللي بتحصل في الدوشين، لانه بس عشان الزمن ما قدرنا ندخل يعني في الباثوفيزيولوجي وكده. انا عندي جين ميوتيشن اثرت لي على الديستروفين جين. الديستروفين ده مهم عشان يطلع لي البروتين اللي هو ده الباك بون بتاع العضله، وبيوصل لي a lot of other proteins ويعمل لي لهم توصيله مع الممبرين to stabilize العضله. اول ما يحصل اي contraction، حاسه انا I am contracting وريليزنج يدي، الحركه بتاعت الكونتراكشن امسك وافك دي في اللحظه دي، انا لو ما عندي proper الناس اللي عندهم الديستروفينوباثيز بيحصل بريك داون وبيحصل a lot of leakage وانفلاميشن في المصل ذاته، لانه الباك بون التصبيره بتاعت العريشه ذاتها الكبيره المثبتة ما موجوده. الانفلاميشن اللي بيحصل around the problem دي secondary to the lack of the protein، ده اللي انا targeting به الستيرويدز. الستيرويدز as an anti-inflammatory يقللوا لي المشاكل اللي حصلت في الديفكت بسبب الديفكت.
Another question: when to start steroids and when to stop steroids in patients with DMD?
So when to stop steroids, ذكرتها قبل. Nobody knows. Basically the jury is still out. We do not really have evidence to say والله يا جماعة نوقف الستيرويد في عمر 20 سنة أو في 25 سنة. No. إحنا نقول إنه الستيرويد بنبداها دايما. طبعا الأطفال ديل تجي تلقاهم ماشيين كويس جدا جدا 4 سنوات 5 سنوات between 5 and 6 دي الحتة اللي بيحصل فيها بداية الديتيريوريشن بتاع الفانكشن. يعني شنو البروكسيمال مايوباثي حقتهم بتبدا تبقى لي واضحة، بقى عندهم difficulty getting off، يعني الجاورز مانوفر بقت واضحة، وده عادة بيكون around the time of diagnosis. although I have to say even in very modern countries diagnosis can be very much delayed يعني. لكن الفترة بتاعت ما بين 5 to 6 دي a lot of people agree إنه usually this is when you start. هم أنت بتتابعهم من الدايجنوزيس، تعمل النورث ستار امبيولاتري اسسمنت حقهم، وأول ما تشوف السكورز حقتهم بادية تقل usually around 5 to 6 that's when we start the treatment of steroids.
Thank you very much, Dr. Maha. Once again, would like to thank you for the excellent presentation.
الله يديكم العافية والله.